It's actually a case. And I was thinking about a case that's worth your time. And I did this case last month, and it's a mix between complication, complex, and clinical decisions. So no disclosures related to this talk. She's an 80-year-old female. She's known diabetic, hypertensive, AFib. She had severe AS and had self-expandable valve in 2019. At that time, in pre-TAVI workup, she was found to have osteal RCA, osteotoprox RCA lesion, and it was fixed prior to the TAVI. Her EF is running around 40 to 45%. So this is her angio pre-TAVI. We can see here, as per the operator who did the case, that nitro was given, so it was not a spasm, and it was a real disease. And it was thought at that time to fix it pre-TAVI. Remember, this is in 2019. A stent was placed in the proximal osteal RCA. However, unfortunately, I think it was missed the ostium. So following up, they placed a second stent, hoping to nail the ostium. And this is the final results they had at that time. That was 6 years ago. Moving forward, she had the TAVI, self-expandable, immediately after this procedure. And then only 3 months post-TAVI, she came with this significant ISR. At that time, it was just ballooned and left with this residual disease. That actually did not last for longer, so this lasted her for a few months, and then 1 year post-TAVI, she came again with the osteal lesion and progression also for a distal to the stent lesion, probably in the moderate to severe range. However, at that time, she was an AFib as well. This is the other angio that shows there is significant disease extending outside, and maybe the ostium at that time was not covered as well. A stent was placed in the mid RCA to cover the progression of the disease there, and also the ballooning of the osteal lesion, and she left with this results. This gave her around a couple of years, and then she came back again with fast AFib mainly, but also progression of the ISR, mainly in the overlap of the 2 stents. That time she was ballooned and DCP, and left with this. So she presented a couple of months ago, which is 6 years post-TAVI, with this angio with the RCAs completely CTO'd. And at that time I was called by a colleague to discuss if there is a retrograde option for this patient. And we can see there is a good channel, and maybe the occlusion site is actually rather short. But she was in fast AFib, so everyone thought, okay, at this time this lady had enough in terms of multiple revascularization, so maybe medical therapy should be attempted. AFib was really controlled. Anti-anginal medications were maximized. There is no room in the heart rate or the blood pressure. And I saw her in the clinic, and the lady could not go to the bathroom without symptoms. So I decided to bring her back and attempting this. Knowing the anatomy from before, I was hoping for an anterograde approach. But if we need a retrograde approach, I think there is clear septal channels going back. But luckily, when we brought her, obviously, with long valves, you struggle with engagement. So I used a 5 French guide, and then managed to anterograde to find the vessels, confirming the position, and then did some ballooning to understand where is the disease. And it looks like distal to the stent as well as in the osteal part. So IVUS at that time to understand what's happening, and we can see here after some ballooning we see some lumen vessel, but there is significant new intimal hyperplasia. However, as we're coming down to the or up to the ostium, we can see some calcification, probably calcium nodule, as well as some calcification at 11 o'clock. And maybe the ostium part of the ostium, just 1 millimeter, maybe it was missed at that time. And the right is the still image of the calcification. So did significant ballooning and shock wave. And then, the definition of insanity is keep doing the same thing over and over again. So we thought maybe the best thing we do, if there is a part that was missing the ostium, and maybe there is some interaction with the valve, is actually to flare a stent outside with 4 to 6 millimeter as the sweet spot, hoping that this will do her some good. This is not the last position of the stent. It was brought back a little bit and then flared out. For people who does these procedures, they understand that this is usually a continuous struggle during the procedure. And we can see here manipulating the guide around the valve. So we left her with this, with S angiogram, complete resolution of the symptoms and follow-up visits. And I guess I would leave you with more questions than answers that open for discussion. That should we think differently about patients who has osteal disease and you're planning for TAVI? Should we treat them differently, either with only DCP or with a stent protruding outside? And is there an increased risk of ISR in patients who has osteal stents and in the settings of TAVI? The other question is, do we actually, if there is an osteal lesion, do we actually need to take in consideration the choice of the valve between a long or a short skirt? Thank you so much.
Excellent.